Good afternoon, ladies and gentlemen. My name is William Sanderson-Mayer. I'm the managing editor of MedicalBrief. Welcome to this first in a series of 5 webinars sponsored by the Professional Providence Society, PPS, with Professor Robin Wood of the University of Cape Town and of the Desmond Tutu HIV Foundation. In the series, Professor Wood will be looking at the fast-moving research and developments around the COVID-19 pandemic. But most of all, we're hoping that we will have sufficient time and that we can explore in greater detail with medical practitioners the problems and experiences that they are having in the front line with one of South Africa's most eminent medical scientists. Professor Woods is director of the Desmond Tutu HIV Centre. He's a member of UCT's Institute of Infectious Diseases and Molecular Medicine, a National Research Foundation A-rated scientist, visiting fellow at Harvard Medical School, honorary professor at London School of Hygiene and Tropical Medicine. He served on numerous scientific advisory boards on PEPFAR, the United States President's Emergency Program for AIDS Relief, the World Health Organization, the International AIDS Society, the International Partnership for Microbiocides and ARAS, the TB Vaccine Initiative, as well as the Bill and Melinda Gates Foundation. Professor Wood is one of those forthright scientists who rigorously follow the evidence no matter where it takes him, and is always completely indifferent to the politicians and the politics around medicine. So it's great to know that he'll be interpreting COVID for us over the next months. And we'll kick off quickly. I just want to discuss the format. We'll have half an hour of discussion. In the meantime, please post your questions on the Q&A as written questions. We'll collate them and put them to Professor Wood at the end, and try and cover as much ground as possible by actually putting them together as omnibus questions. Robin, good afternoon, and thank you again for being here today. Before we go into what you're ostensibly going to be looking at, the whole matter of prevention and treatment and research around that, all the excitement that this week has created, that has greeted the Oxford dexamethasone study, is that the problem solved now? Can we all go home, or where are we? Where does it stand now?
It's a step forward. I don't think it's going to be a panacea for everything. It's very large numbers. So even though it's not been peer reviewed at the moment, it looks as though the numbers are very significant. I mean, it's a study of about 6,000 patients, and the effect is pretty significant. So essentially, the death rate amongst people on ventilators was decreased from 41% to 27%. And with these large numbers, that's very statistically significant. The difference, that's when they gave the dexamethasone at quite a low dose. This is 6 milligrams a day. When they gave it to patients with a little bit earlier disease, those are patients that were oxygen dependent, then the decrease went from 25% mortality to 20% mortality, which is an effect size of about 20%. Again, because of the large numbers, this reaches statistical significance. But really, in part of the way, the answer, it's not going to solve all our problems, because if you give it to people with an earlier stage of disease that don't require oxygen, there was no benefit. They said there was no significant decrease, but in fact there was a slight increase. And again, we need to watch that space. But so what it's showing you is that if you don't need oxygen, dexamethasone is not going to be any help for you. If you do need oxygen, it's a little bit of a help. And if you're on a ventilator with a very bad prognosis, it will improve that prognosis. And this drug has been around for a long time. Normally, it's recommended for patients with so-called ARDS, severe respiratory distress, and it's usually used at much higher doses than this. So this, I think the big group for me is that oxygen-dependent group that we can improve their prognosis and stop them going onto ventilators. So I think that's the big group. But obviously, the patients on ventilators are a relatively small group of patients with a very poor prognosis, but that prognosis is now a little bit better. But the condition they had used to be treated with dexamethasone high dose as part of normal therapy.
So it's basically a continuation of a therapy that's already happening.
For the ARDS, that's the patients on respirators. It's been recommended to give patients with a very poor prognosis with ARDS higher dose, but it's never been given to patients with just oxygen, not requiring ventilation. So essentially, this is one of these drugs that it damps down the immune system, and that's a good thing when you've got an over-exuberant immune system, but not if you've got a well-functioning one. So that's probably why the drug's not going to be of use to patients with much earlier disease.
Robin, does this mean that the most promising route forward is going to be research into steroids, or is it going to change the path of the research that's taking place now?
I think that this is a sort of typical of medical science, that we tend to focus on the sickest of the patients, whereas if you want to make a public health impact, then you need to stop patients getting the disease. You need to stop them progressing to disease. You need to be able to treat early disease. But focusing on very late disease is something which is done in Western medicine, but doesn't really make a massive impact on the population effect of a public health approach.
And
so the answer
yes,
is no. It's going to make COVID disappear. It's not going to change the numbers a lot, but if you happen to be sick, very sick, you would be very grateful to have access to this drug.
And what are the implications for the research that's been going on into hydroxychloroquine and the related drugs?
So chloroquine, as you know, it started off as being a very attractive option because it was cheap. It had been given to many millions of people over decades. And it had very good in vitro data for switching off viral activity in the test tube. And therefore, there were lots and lots of studies started in China. The reports were that it was beneficial. And then we got a little bit of a French small study which showed that it was beneficial. But subsequently, we've got equivocal results for prognosis, for prophylaxis. The veterinary study in the US. Then we had a problem with the very high dosage. So the dosage that was given in, for instance, the Brazilian study was probably 4 or 5 times higher than normal, and they reported extra deaths. So there's although the drug was cheap, it was safe. It was safe in the doses that were used for malaria prophylaxis. The higher doses appear to be cardiotoxic, and a lot of the patients with COVID do have cardiac comorbidities. So therefore, the high dose is really problematic. And the Brazilian, I think, was 12 grams given during the course, and that increased mortality. So it doesn't look as though there is a big effect size as opposed to the dexamethasone study. So some people are still protagonists for it. It is in the test tube, it's an ionophore for zinc, and people are saying, oh, well, you didn't give it with zinc. But it doesn't look as though the effect size is really going to make a big impact on COVID, either for treatment or for prophylaxis. But people are still looking at it.
Robin, let's turn then to the prevention part of that equation. And when we spoke for the first time in April, you were very emphatic quite contrary to the advice given by the World Health Organization, that homemade masks and masks for the general public were necessary, essential, and people should do it immediately. You've since been proved correct on that, of course. And you also stressed effective testing. What do the statistics and research indicate South Africa should be doing now, and maybe what we should be doing differently? How do you see the picture for prevention at the moment?
I think you can separate that into factors which impact on the transmission itself and factors which impact on the individuals at risk of getting infection. So certainly my strong view is that we know that this disease can be spread by 3 different methods, although in the South African guidelines they say it's only 2 methods. But essentially we can contaminate the surfaces around us, and that's fomites, and that's helped by hand cleaning. The second one is large particle production, which probably is mainly produced during speech. As people articulate their vowels and consonants, they produce a shower of very large particles, and that can be easily stopped by a cloth mask and by a reasonable distance. The third one, which I think people are not looking at, is the small particles that are less than 5 microns, which remain airborne for prolonged periods of time. This is the same method of dissemination as TB, tuberculosis. And I think that has been ignored and has been played down by the WHO and by our own advice guidelines. And I think that's probably a mistake. I think that the way that you control that type of particle is by old-fashioned ventilation. You can substitute ventilation with UV light and protection with N95 masks. The policy in many parts of the world has been, unless you're doing something specifically to produce aerosols, you can get away with a surgical mask. And I think the evidence from Europe on the very high infection rates amongst doctors show that that's probably wrong. I don't see why transmission shouldn't be by small particles. We know that everybody produces small particles when they take deep breaths in, and when they shout or do any loud respiratory, forceful respiratory maneuver. The problem is we don't know which of those 3 methods of transmission is most important in each and every scenario. So you can imagine in a creche, you probably think fomites and kids contaminating surfaces would be very, very important. I think probably in hospitals, small particles become more important. So that's the transmission side of things. I think we're missing out on the old-fashioned ventilation, which I feel very strongly about. I think the other thing that follows from that is that we have to recognize that most of the transmission of respiratory diseases is indoors and not outdoors. So I think that the emphasis on staying 2 meters away from people outdoors, I can't see the rationale for that. Then the next part of your question is, are there people that are more susceptible and less susceptible to getting the disease? So we suspect that people who've already had it, that produce antibodies, are probably likely to be somewhat protected. Certainly that was the case with MERS and the SARS. But what I'd like to lead that into, which I suspect the question is what about vitamin D status? There is a problem in temperate zones that people with darker skin color are dying and getting this disease much more frequently than other people. And there's a lot of debate about that. But one of the causes of that could well be a vitamin D deficiency, because vitamin D is produced during exposure to sunlight, which in the northern hemisphere at higher latitudes is inadequate. And we know that there's a lot of difference between countries which has not been explained by our normal SIR modeling studies. And if we look at the countries which have been particularly severely affected, certainly a lot of that effect could be explained by vitamin D status. So vitamin D, there's some individual data from let me see, Philippines. They picked up that patients with severe disease compared to mild disease had much lower vitamin D. Same thing was found in Indonesia. Patients dying had lower vitamin D levels. And there's been a couple of studies looking at European countries and linking the infection rates with the background deficiency of vitamin D rates. And it's all circumstantial evidence, but there's an awful lot of it. So there's a biological plausibility, and there is, it certainly looks as though it could explain a lot of the difference between different countries. And it's cheap. The problem is that the people who would benefit from vitamin D are those that are deficient in it. It won't be a benefit to patients who have adequate stores of vitamin D. So being replete for the vitamin is good. Having excess of it is not going to be any better. So whenever you look at the studies, you realize it's that group of individuals that are deficient that are most likely to benefit from vitamin D. And in Europe, some countries use fortification of food substances to a high degree. Again, Finland is very aggressive on that, and Finland had very low case rates and case fatalities compared to other countries. Italy, interesting, northern Italy, elderly females have an incredibly high deficiency rate of vitamin D. So it could explain some of the strange anomalies between nations. It has a rationale at an individual, group level and at a country level. And it's relatively cheap to give to individuals. But the only people who are going to benefit are those that are already deficient in it.
Given what's the likely selling of vitamin D around it, supplementation around that, as people pick up on the issue in the media, what are the levels of vitamin D deficiency in a country like South Africa?
Well, there's not a lot of data, but I think if you look at the studies that have been done, it's relatively low. So at population level, I think it was in the order of 10%. Whereas in northern Italy, I think for the elderly, it was 80%. And in Belgium, which was particularly hard hit, it was about 44% deficient. So we're relatively better off than most countries. And again, could that explain the different trajectory that we've got compared to it? I suspect it's going to explain some of it, but not all of it.
I want to digress for a moment. I just noticed that, I hesitate to contradict our president, but I saw in his question and answer the other night that he said that we're not collecting statistics according to race, which seems to me odd since we collect statistics on race in every other sphere, but especially since there is this differential between African Americans and white Americans, and also British, Asian, and minority ethnic groups in the United Kingdom. The NICD did release some statistics recently according to race in South Africa, and that showed that 63% of South Africans were Black African South Africans. What do you make of that?
Well, I think if there's a sort of scientific rationale for why there would be difference in races, then I think it's appropriate to collect that data. I think that we have a rationale here that pigmented skin is important, but it's really important in temperate northern zones. It hasn't been really shown to be important here. So I think it might be of interest to see if there is a big difference. I'm not sure that in this country that it's going to be that important, but I don't know on the data, but certainly it seems to be that African Americans are at particularly high risk. Doctors in the National Health Service have very high rates if they come from Indian subcontinent and from Africa. which is of interest because they wouldn't be of lower social economic status. And that's one of the problems, is that if we look at race, it's confounded by other issues. So I think I would restrict it if there's a biological plausibility to it, but there is a bit of a plausibility here because of the vitamin D status, but I don't know of any data that says that indigenous African population has lower vitamin D than white population here. I just don't know. If it did, what are we going to do about it? My feeling is that whoever it is that's deficient in vitamin D deserves to have a cheap supplementation available to them. So it might be some sort of scientific interest, but I don't think it's going to be of any practical interest on how we deal with the epidemic. There are so many other social factors that are important. For us, vitamin D is probably going to be relatively small. It explains the difference why we're doing much better than the West, because we have different demography and we have less vitamin D deficiency, but I'm not sure that it really justifies going into a racial collection of data. And be fairly
Robin, won't you lay out where the research is taking us in terms of treatment and what South African practitioners should be thinking about and looking at in the near future or immediately in terms of treatment?
Well, one of the problems that I have with our response to the epidemic is that I'm unsure what the overall strategy is. The strategy has changed from flattening the curve. It could be to try and decrease mortality, but it seems to now be to decrease incidence rate. And I think we need to be clear as to which of those is our strategic aim, and then to aim to try and achieve that. If it's to decrease mortality, then as we said right at the beginning, it's protecting people with comorbidities, it's protecting old people in homes, it's looking out particularly for our healthcare workers. If we get diverted into saying, well, we want to just decrease cases regardless, then the consequences of that is you start closing down schools and things for very little benefit in the way of mortality.
So what does that mean for testing, as there's been a lot of criticism of the government's approach on testing? What's your view on that?
I think they've done quite a good job. I mean, there's 1.2 million tests have been done. It's quite interesting that it's been a steady increase in numbers of tests, which has been associated with a steady increase in the test yield. So it's gone from about 2% up to almost 8%. I think it gives us some idea of what's happening. I think the mortality data is much more compelling from my point of view. And if you look at the epidemics around the world, even the global epidemic, the number of cases is going up with time, but the numbers of deaths per day are staying stable, which is quite an interesting phenomenon, which I think is basically good if your strategy is to limit mortality. It's not good if your strategy is to just limit infections regardless. So I think the testing has been as good as we could do. I think it's amazing to get up to 1.2 million in a country of 66 million people, or 60 million people. I think it gives us an idea of where the epidemic is. I think the mortality rates are particularly important. And if you compare us with other countries, it looks as though we don't have a hidden mortality that we haven't picked up. In excess mortality from what over and above what we'd expect. I mean, I was puzzled by the Ecuadorian experience where it looked sort of medieval. People were dying in the streets, etc. And yet when you looked at the official results, the mortality rates were relatively low. But if you look at the excess mortality, it was actually high, so they weren't picking them up. I think the evidence is that we've got a reasonable handle on our epidemic. Our problem, well, not a problem, our conundrum is why is the Western Cape affected when other provinces are relatively lightly affected? And I think that shows that there are many things in the susceptibility and the force of infection, the RO number, that are different in different places, that we don't understand all of them.
Thanks, Robin. I'd like to, if you're amenable to it, unless there's something you particularly want to pick out now, is move on to the questions, because there's a flood of them coming in. Is there anything that we haven't touched on that you'd like to touch on?
We haven't touched on other treatments.
Yeah.
There is remdesivir, which seems to have some ability to decrease hospitalization, but I don't think we've got much experience of it here. We've got tocilizumab, which is thousands of dollars for a shot, which seems to have some effect on the cytokine storm. But these are, again, the Western focus on the end stage. I think that we should be looking at the earlier stages and making sure that individuals that have this diagnosis have reasonable nutrition, are screened properly for progression, and those are the things that are going to make a difference. But we do have this concern that hospital systems can be overwhelmed. And I was trying to think about this a little bit. It's quite interesting that we have 300,000 TB cases a year and 63,000 TB deaths a year, and yet that doesn't stress our hospital system the same as 1,500 COVID deaths. So it's interesting that I think our healthcare systems are not particularly adept at dealing with respiratory transmitted diseases. And that's part of the reason that we're suffering so much from that. That's just an observation.
Thanks, Robin. I have a question here from Olivia Liddle. In those patients with mild to moderate COVID, being managed at home, would prednisone be a consideration early on? And will studies only focus on dexamethasone and those who are inpatients?
So I think, first of all, the rationale for steroids is to damp down an overexuberant immune response. So I don't think there's a rationale for giving it very early on in disease. And I think the latest study, which is a preprint that's come out from the National Health Service in the UK and Oxford model, that actually showed, they said non-significant, but there was an increase in mortality when it was given to hospitalized patients that didn't require oxygen. And I think that means that there is no way that we would want to be putting that out like SMART is, to give to large numbers of people. There's no rationale, and the evidence that we have at the moment is that it's potentially harmful.
Dr. Ingram Anderson asks, when should we begin with anticoagulants?
So this is a treatment question for hospitalized patients, and there are several components that are monitored. I have to point out that I'm not looking after patients at the moment, but what I'm aware of is that you have inflammatory markers such as ferritins and C-reactive proteins, which go to very, very high levels, particularly the ferritins. And that's an indication of an overexuberant immune system, and that's when IL-6 blockers and those sort of things are measured. And the other one is looking at the breakdown products of clotting, intravascular clotting, and D-dimers are one of the things there. So I think the choices there for intensivists are, most patients are going to go into hospitalization and going to be immobilized for some length of time, are given low-dose heparin regimens, but those with raised D-dimers I think usually go on to full anticoagulation. I think that's the US practice.
Again, a treatment question. Taba Mashigo asks about the benefits of remdesivir early versus late intake.
I'm only aware of it being used in hospitalized patients. I'm not sure, its accessibility is limited, and its final price I see is somewhere between $10 and I think $20,000, depending on how effective they think. At the moment, it seems as though there's evidence in the States it decreases hospitalization from, I think, 11 days to 7 days, which has major economic benefits for the American health system, and therefore that will determine its final price. But it's still, the data is suggesting that it does have some effect on speed of recovery, but not, I don't think it's been shown to have a mortality benefit to date.
Robin Duarte, any comments from Professor Wood regarding findings that individuals with blood type A are at increased risk?
Well, I find it reassuring because I am blood group O, and that's the low risk, and the A is the high risk. I don't know what the significance of that's going to be, because no one can change their blood group. It may explain some of the variability, as I pointed out before. There's a lot of things that we don't understand. Vitamin D we thought might explain some of it. Blood groups may explain some of it. But vitamin D we can do something about. Blood groups you can't really do much about. So it's an interesting and real observation, but I don't know that it's of great significance.
Liesl Rosenberg, what about the racial differences in ACE receptors and activity? Could that explain the differences in infections?
I think that probably that's more likely, and then I'm hypothesizing here, more likely to explain the difference and the relationship to comorbidities. I mean, this disease is very, very strongly associated with diabetes and blood sugar control, and also hypertension. And I think those are conditions which are much more likely to have impacts on vascular ACH2 receptors. Racial differences may well be there, but I don't think they're going to be anything as important as the comorbidities. If you look at overall mortality, and I've got a 19-year-old son, so I calculate that his mortality risk at the moment in South Africa is 1 in 2 million. And if I go to the elderly above the age of 70, which might strike home for me, then I have about a 200-fold higher risk of succumbing to this disease. That's the thing that drives it. It's not going to be racially driven. It's determined by comorbidities and age. The data at the moment, that's by far and away. Whether or not there is an independent small racial effect because of ACE2 receptors, I don't know, but I doubt if it's going to be of any great significance compared to the other massive difference. As your age goes, this is unlike flu. I mean, flu is a U-shaped curve. This is just an exponential curve with age and with comorbidities. The risks to the elderly and those with comorbidities are 100-fold higher than young people. So I think that means that that's going to quench any racial difference that you're going to pick up.
So genetic susceptibility is not a big issue at all?
I wouldn't say that. You're saying, I think, race has a large socioeconomic factor to it,
yeah.
And its other factors are relatively minor. We've come across one in pigmentation may be more linked to vitamin D, and therefore it may be slightly more. But your question was slightly different worded. You said that immunity.
Yes, sorry, I'm segueing into a different area.
I suspect that there are individuals whose innate immune system makes them less vulnerable to respiratory diseases. I suspect that there are some people who have met diseases which cross-react with this. There was a Science article which showed that blood taken several years ago contained T cells which responded and controlled COVID-19 virus, even though it wasn't targeted at the spike protein, it was some of the other proteins. So what it says is the innate immunity will be different, your educated immune responsive will be different, your vitamin D status will be different. So there is a lot of heterogeneity within the human population, most of it not explained by race.
Dr. Anderson asks again about the chloroquines, saying they have side effects in the longer term which affect the retina. As a rheumatologist, the retinopathy may sometimes occur fairly early on. One is alarmed that many patients have been committed to prolonged prophylactic treatment. Your opinion?
So again, I think this is real. It's to do with dose. Many years ago, I ran a small clinic in Central Africa and used chloroquine for my own family, etc. And at the doses that we were giving, it was relatively safe, and although I looked for retinopathy, I didn't find any. I noticed that the questioner is a rheumatologist. Rheumatologists use much larger doses of chloroquine, and I think they need to be appropriately aware of the side effects. So again, I'm not trying to give chloroquine a clean bill of health, but at the dosages that were used for chloroquine, for malaria prophylaxis, it was very well tolerated over many decades. We know that in the Brazilian study, in a short period of time, with a 12-gram dose, they had cardiac problems, and I would agree that prolonged use would predispose to retinopathy, which you can pick up with color charts, etc. But it's a potential problem. But I have treated hundreds of patients with chloroquine in my earlier years and never saw a retinopathy from that. But that's a totally different condition than giving very high doses, where we're seeing cardiac and potentially you might see visual field problems.
Robin, there's a lot of interest in transmission by asymptomatic patients. Do you want to talk about that a little bit?
Yes. I think it probably is very significant. As I mentioned earlier, I think that the modes of transmission are going to be of variable importance in variable settings. But I think there is quite a lot of evidence that asymptomatics may transmit. And the question is, what is the population attributable risk of this? And that's the key. So if somebody is a transmitter and is unaware of it, and they happen to be doing it for a long period of time, then they will contribute to the population attributable risk much higher. Attempts to measure that, I'm aware of a couple of studies, one of which was around about 15%, and the other was of the order of 60%, claiming that asymptomatic carriage was responsible for that. I think in a conversation with you, you came up with a recent article which was around about 45%, was it, or 60%?
Yes,
anyway,
45%.
It's an unpopular sort of thing to say because you can't target it. And I think that's maybe why the WHO wanted to focus more on cleaning hands, etc. But I think it is significant. I think that we have a problem that if you look in Europe, the number of medical individuals that got infected, particularly high in Spain. I was just talking to someone in London hospital, and 25% of their population tested positive with antibodies. So I think it's real. Its absolute magnitude, we don't know, but it occurs, and how much it contributes to the overall transmission is unknown, but I suspect that it will vary tremendously on the environment that you're in.
There's an interesting question here. Considering that the first outbreak was in the wet food market in China, and the new outbreak, there's now a new outbreak in the meat market, as well as the news that 650 people tested positive in a meat processing factory, is there a meat transmission link here? In other words, are vegetarians safer?
Yes, in the US, the meat processing plants were related to very high incidence rates of COVID. It was attributed to the environment they were working in and transmission from human to human. I don't think anybody invoked from the frozen carcasses to the humans. On the other hand, early on, COVID, there are many COVID viruses which affect animals, and the origin of the infection probably came from a species jump, and that obviously would be associated with meat and meat products. Not dissimilar to Ebola with bushmeat practices, etc. But the transmission at the moment is from human to human. And I don't think there's any evidence in the recent outbreak in Beijing that this is a new strain, that could be checked to see whether or not this is another species jump. But at the moment, the feeling is that this is just human to human transmission that has been reintroduced into a susceptible population.
Two treatment questions or management questions: aspirin and convalescent plasma.
I'm not aware of any real rationale for why aspirin should be of use in this disease. Certainly conditions like Kawasaki's, I think, which has hit the news in the UK, is predisposed to by those drugs. Convalescent serum is particularly interesting and has a rationale behind it, because it was used in the original SARS and MERS epidemics and was shown to be beneficial. It has problems for widespread use. You have to find the appropriate donor. You have to do screening and a little bit like blood matching. And one donor can normally produce enough treatment for 2 patients. So the availability of it is very limited. I think that there's something like 6,000 units have been given to 5,000 patients in the US, and I haven't seen any rigorous analysis of those results. But certainly it has a good rationale. It's been useful in other diseases, from Ebola to other coronaviruses, and it is being used, but it has a lot of practical limitations.
Christine Skitter, also looking at that area. Christine Skitter asks, is there any evidence of glutathione intravenous therapy being beneficial in the early stages for hospitalized patients? And then what about NSAIDs in the treatment?
So superoxide damage has always been recognized as being part of the pathogenesis, and people have proposed that N-acetyl cysteine and other drugs that can impact on superoxides may be useful. This story has been around for decades, and yet I'm unaware of any disease that's actually been shown to have a clinical benefit from it. So again, it has a good scientific rationale, but I'm unaware of any data that actually justifies. On the other hand, these drugs are relatively benign and not noxious, and I sort of think about it in the same way as the vitamin C story, that you know, people are protagonists for these things. There is some rationale behind it, but really it hasn't ever come out with hard data. but the modalities are relatively benign and therefore wouldn't feel too strongly about not doing, but there's no evidence really that it's going to make benefit. And the NSAIDs, there was an interesting article early on that they were harmful. Now I think there's, it's probably relevant to the pathogenesis.
You have touched on it, but would you like to expand on this thing of people who are asymptomatic but test positive? Is this because the test is not so good, or is it something else that's causing that?
So the tests are pretty good. I think the RNA assay is very good. There's obviously problems with sample collection. So if you don't collect an adequate sample, it's not going to be as sensitive. There's also the site of infection. So it seems as though you get increasing sensitivity of the assay as you move from the upper respiratory to the lower respiratory. So bronchoalveolar lavage has a much higher positivity rate than a throat swab, and a nasal swab has better sensitivity than a throat swab and a sputum has. So it's graded, but the sensitivity is pretty reasonable. I think if you look, in the Iceland, which is a small country with a lot of testing, I think they claim that 40% of people weren't aware of symptoms. So you have the next problem is that you could be symptomatic, but not think it was particularly unusual. So defining asymptomatic is a little bit tricky, but there's no doubt that it does occur. And I think the majority of the cases will be because of the variability of the immune response to the virus rather than an inadequate testing. But there's no doubt that some people have tested negative, but that's the sensitivity of the test. And the sensitivity is certainly, looks like it's, from a nasal swab is above 60%, but it's not 100%. So there will be the odd ones that you have to repeat or get a better specimen. But the same, you've got to remember in TB, we find a sputum positive diagnosis in about 50% of cases. So in this disease, we're doing much, much better than that.
Again, with testing, Nelson Ikaba asks, is there any hope for us for use of antibody tests for diagnosis in the near future?
I think it's probably not going to be as useful for diagnosis, but I think it's going to be very useful for really understanding what has taken place. As you said, if there's a significant number of people who have been asymptomatic and not aware that they've had the disease, knowing that a large proportion of the population is relatively immune to a new infection from an epidemiological point of view is really important. Just to sort of go anecdotally, a student of mine that's in the UK just recently tested positive on the serology, but negative on the nasal swab. He's a medical practitioner, and that's actually quite reassuring to know that for him. He's going back to his family and meeting his grandparents, everything else, knowing that he's had the disease. So I think that the antibody tests will be very useful. I think they probably could be at the moment, but they haven't been allowed in. I think SAPRA has not registered any as of yet. So we're awaiting them, but I think it's going to be a very useful adjunct. Its actual ability to diagnose acute disease, I don't think there's any evidence from anywhere else that it has proven useful for that. It's usually shown that someone has had it asymptomatically or recovered from asymptomatic infection. And obviously you can't really give hyperimmune convalescent serum unless you could measure it. And this is one of the ways of measuring it.
Professor Wood, we've had a number of questions on reinfection. Bongila Mabilani says, I have a few cases, especially among nurses and doctors. How can I explain this? Might it be the tests? What is the evidence?
Yes, it might be the tests. People have been aware that some individuals take a long time to clear the virus, and therefore when you're using a test that measures virions or the RNA in virions, that causes a problem. Whether people have truly recovered and then been reinfected, as far as I'm aware, I don't think there's any hard evidence for that. Generally, most diseases like this, where antibodies are produced, there is some immunity linked to that. The level of immune globulins that are produced by individuals vary tremendously. I'm aware that some people with relatively mild disease may get less in the way of antibodies, and ones with severe may get more. But I think generally the feeling is that individuals aren't getting infected more than once. But it could be that the data, more data will come out later to suggest that that is the case. Because of the variability of immune response, wouldn't be totally mind-blowing if that was the case. But at the moment, I think the general feeling is that it's not, that it's a once-off disease. Maybe a long time to recover, but there's very few proven recoveries with subsequent infections. But the sensitivity test would also potentially cause a few cases like that.
With the hotspots in the Western Cape seemingly being highly concentrated in the Cape Flats areas, is there perhaps a link there to TB in those areas? In previous years, TB was highly prevalent in Elsie's River, for example, and that's a hotspot as well. Is there, or could there be an increased susceptibility there?
So there could be. On the other hand, remember that we said that one of the modes of transmission could be identical to TB. So if you've got a lot of people transmitting in conditions where TB can be easily transmitted, then why wouldn't this disease be transmitted? The association with TB has been shown, I think, a slightly increased risk amongst people who've got active TB. I think the interactions with TB are of interest. I think TB is a disease that affects poor populations. It's a disease which it gets propagated in crowded, poorly ventilated areas, and so does COVID. And then we had the added problem in that the symptoms with which people present would look very similar. So it's something which I think hopefully South Africa will be able to dissect out a little bit. But certainly there will be associations because of many factors.
David van der Merwe asks, what's the significance of previous BGC immunization, and is there any place for re-immunization?
Well, that is a subject of study. I think there's a large study that's been set up to look at that. There are a few little ethical issues there in that there is a worldwide shortage of BCG at the moment. So we don't want to take it away from children, which we know would benefit from it, in order to pursue a scientific hypothesis which may not be of great significance. I personally am a little bit skeptical about it because virtually everybody in our poor communities is already infected with TB. Why giving them some antigens that are slightly less than a TB infection in a BCG bacteria seems a little bit stretching it. On the other hand, we know that it has pretty impressive impacts on immunity against certain tumors in the bladder, etc. So I think the hypothesis is there. I think it needs to be studied with a suitably powered trial, and keep an open mind, and it would be interesting if it came up as being positive. But at the moment, it's there's enough data to make it an interesting hypothesis, which should be investigated.
You spoke of comorbidities such as hypertension and diabetes, but have there been any other studies on other conditions like hypothyroidism?
I am not aware of any. I think the strength of vitamin D is quite strong. I think the ability to show a link between hypothyroidism and COVID would be very difficult to design the study, but as the numbers increase, then the analyses and the power of analyses to show smaller associations will develop, but I'm not aware of any at the moment.
It's the subject of one of your later webinars, but I wonder if there's, again, a lot of interest in herd immunity. Do you want to just bring us up to date on where the research sits on that?
I think people get very upset by the term. Population immunity, I think, is the better term. There's no doubt that all the respiratory illnesses that have plagued us historically have eventually been sorted out by lack of susceptibles. And that's really why we're talking about whether or not people get reinfected. If they did, then it would mean that population immunity would not develop as well as it would do if there's a strong immune response that lasts for a period of time. So I was looking at some data, trying to imagine how would we know what happens if we had done nothing. And interestingly, in Ohio, there is a prison called Marion, where it looks as though they did nothing. There was no hand washing. The beds are within 3 feet of each other. There was no social distancing at all. And if you look at Marion, there were 2,500 individuals, prisoners there. 80% of them became infected, and they had 88 deaths amongst those. So they had a 3% death rate. But it's now been labeled as burnt out. And the reason it would be burnt out is because they've run out of susceptibles, because 80% of the individuals have had it. So there's no doubt that in a closed setting such as that, population immunity did affect the epidemic. It's come to a close. Extrapolating that to other populations is a little bit tricky, because, as we talked earlier, we don't know that everybody is equally as susceptible to it, but certainly the disease will not prosper when it runs out of appropriate susceptible individuals. For whatever reason they become less susceptible, that's going to have a big impact on the epidemic curves.
Thanks, Robin. We just about out of time, so I won't take any further questions. I'd just like to thank you again so much for giving us such a generous amount of your time and your expertise. The series, it is a 5-part series, and we invite you to register for further webinars. You'll find details on MedicalBrief, and if you've attended this one, you'll certainly be on our invitation list. Thanks very much, Robin.
Thank you, William.